Welcome to the GLP-1 RA series from the American Heart Association, sharing insights on the heart and kidney health benefits of GLP-1 receptor agonists. This series is supported by an educational grant from Novo Nordisk, CE and ABIM MOC credits available.
Welcome to Heartbeats from Lifelong Learning and our series on glucagon-like peptide 1, or GLP-1. Today, we will discuss demystifying GLP-1s. This is one of a series from the American Heart Association. I am Dr. Trudy Gaillard, Associate Professor, and the Dr. Vanessa von Wertheim, Chair of Chronic Disease Prevention and Care at the Nicole Wertheim College of Nursing and Health Sciences at Florida International University. I have no disclosures. More than 37 million people in the United States have diabetes, and 1 in 5 of them don't know they have it. Diabetes is the 7th leading cause of death in the United States. Diabetes is a major cause of blindness, kidney failure, heart attacks, strokes, and lower limb amputation. Dr. Rush, why focus on lowering glucose in persons with diabetes?
Well, Dr. Gaillard, I just want to first introduce myself and then answer that very important question. My name is Jane Rush. I'm a professor of medicine and associate director of the Center for Women's Health Research and the Diabetes Research Center at the University of Colorado and the Rocky Mountain Regional VA. I'm past president of the American Diabetes Association and a zealot dedicated to answering questions just like the one posed to me, which is, why would we focus on glucose lowering if cardiovascular death is the leading cause of death in diabetes? And that's because glucose lowering, as we see here in the lower right corner, is a central component of wellness in terms of life's essential 8 cardiovascular risk prevention strategies and behaviors that we can use. When we're thinking about glucose lowering, what we know from studies in people with type 1 and type 2 diabetes is that lowering blood glucose has the property to decrease the complications of diabetes that Dr. Gaillard just discussed. Why we're having this series today on GLP-1s is because glucagon-like protein 1 is a newer drug in the armamentarium to take care of diabetes, and it has both highly efficacious glucose-lowering properties as well as cardiorenal prevention properties.
Thank you. Can you give us an idea of what are some of these agents and how they work?
Well, so many of the agents that we treat diabetes with work by specifically reversing some of the pathogenic aspects of diabetes. So metformin, the most commonly used drug for diabetes, will decrease hepatic glucose output. Other agents will augment insulin secretion. Other agents will make the muscles more sensitive to insulin, but the GLP-1 agents have a really specific mechanism of action. And with the support of our sponsors and the American Heart Association, we have been able to generate a lovely video to tell you a little bit about how GLP-1s work.
GLP-1 is a hormone made within the body. It regulates many functions, including carbohydrate metabolism and appetite. Upon ingestion of a meal, GLP-1 is secreted from the distal small intestine. It circulates in the body and stimulates the glucose-dependent insulin secretion. This is then typically coupled with glucose lowering in the periphery. GLP-1 also decreases glucagon secretion. Decreasing glucagon secretion leads to lower hepatic glucose output. This is a normal physiological change with food ingestion that's impaired in people living with diabetes. Combined augmentation of insulin secretion and decreased glucagon cooperate to reduce hepatic glucose output, which is often elevated in people with diabetes. An additional response to GLP-1 is the slowing of gastric emptying. This effect leads to an increased feeling of satiety and slowed postprandial glucose absorption. Finally, these agents act to increase satiety and decrease appetite in the central nervous system. So, taken together, the ability to slow gastric emptying increases satiety. The integrated effects of GLP-1 on insulin, glucagon, gastric emptying, and satiety underlie the potent impact of these agents on carbohydrate metabolism and weight, making these agents of high importance for cardiometabolic health.
These drugs seem to have a lot of mechanisms of actions. What makes them so unique, and why should we consider them as a first line of medication in individuals with diabetes?
Well, in people with diabetes and cardiovascular disease, they're first line because many of the drivers of cardiovascular disease include obesity as well as other aspects of metabolic syndrome that drive atherosclerotic cardiovascular disease, stroke, peripheral vascular disease. So we should consider these agents because in addition to their effects on glucose lowering, which are quite potent, they also have the property to decrease the number of major adverse cardiovascular outcomes in large pivotal trials for just that endpoint.
Thank you. So, if we use these drugs, actually, how much glucose lowering should we expect to get?
Well, depending where you start, and where you start always kind of dictates where you finish. So if somebody has an A1C goal of 7% or less, because they're a relatively healthier person with uncomplicated diabetes, and they start with an A1C between 8 and 9%, we might expect 1 to 1.5% A1C lowering. In the more potent, higher dose GLP-1 ligands, we're seeing up to 2% lowering. If somebody starts with an even higher A1C, you may see more glucose lowering. But I think that when we think about people with moderately above goal glucoses, we can expect 1 to 2% A1C lowering, which is very similar to insulin, previously the only agent that could get you more than 1% glucose lowering.
Thank you. Now tell me, where do they fit in the schema of our selection of drugs that we can choose when treating people with diabetes?
Well, that's such a good question because this has really been a rapidly evolving target. In the past, when a drug was approved for diabetes, it would just be considered in terms of its glucose lowering efficacy. But because of the FDA guidance in 2008, we now have very big clinical trials that are designed to test cardiovascular benefit. Those studies have shown us that in people at very high risk or with cardiovascular disease, we can see a cardiovascular major adverse event outcome benefit. So if I have a high-risk patient, these drugs can be used first line for glucose lowering. If I have a patient who is not deemed as high risk for cardiovascular disease, then they may be incorporated into the armamentarium along with the use of metformin. For all people, and going back to that life's essential 8, diet and physical activity are the fundamental baseline that all people with diabetes should be used.
That's important. Do you have a schema or a chart that we can share with providers that can be used to help them when they need to make their decisions on what medications they should choose? You brought up some very interesting points. It depends on what their A1C is, as well as other multiple conditions that people with diabetes have.
Such an important question, and one that every clinical practitioner in the office is asking themselves. Not what do I do for all people with diabetes, but what do I do for you, the patient in the room with me for diabetes? And every year in January, the American Diabetes Association releases the standards of medical care for diabetes. And in the 2023, we see a guideline that was also endorsed by the European Association for the Study of Diabetes, which on the next slide will show us how you would be approaching people with diabetes. So on the left are people with a high risk for atherosclerosis, heart failure, or kidney disease. And in those people, regardless of their A1C, you want them on a GLP-1 agent or an SGLT2 agent, which we might talk about in some of our later sessions. If it is a person living with diabetes who is on lifestyle and metformin and still needs glucose lowering, then other factors will fit in, including whether weight is a big priority, whether cost or access to a medication is a big priority, and whether complexity or side effects are a big priority. So this algorithm that may appear complex is really kind of simple. On the left side is people at high cardiorenal risk, and on the right side is the majority of people living with diabetes, where you're really trying to work with them to optimize their glucose control over a lifetime.
Thank you. I think the schema is important because as primary care providers, we all want to have a patient-centered approach and choose the medications that are best suited to achieve the lowering of A1C. You brought up some other factors that make these medications also a great drug of choice. You talked about weight loss, and many of our patients with diabetes are overweight. And you also spoke about decreasing satiety. Do you have anything that we can share with our primary care providers about that?
Well, one is the armamentarium for taking care of people with cardiometabolic disease as a whole spectrum, including obesity alone, obesity with diabetes, and or metabolic syndrome. Previously, what we had in our armamentarium, which is something very important, diet, physical activity, decreasing sedentary behavior, was sort of what we had, but there was a feeling of lack of efficacy, lack of self-efficacy on the part of the patients, lack of efficacy on the part of the providers. We are now in an era where we have medications that we know are safe and even protective from a cardiovascular benefit that can also help facilitate highly effective 10 to 15% weight loss, which we know even has the possibility of leading to reversal of diabetes or decreasing all the other medication requirements for lowering blood sugars while permitting a weight loss. So as we are moving into 2023, we can do so with great optimism for our ability to meet our patients who are struggling to trying to lose weight and either losing weight but then regaining it or failing to lose weight at all. And we can help them do this in a very cardiac safe way. So this is an exciting new moment in medical history.
Thank you, Dr. Roche, for providing a wonderful overview of GLP-1s, their unique mechanisms of action, and how they might fit in the schema of choosing drugs for our patients with type 2 diabetes. One last thing I'd like you to discuss with us, and I know most primary care providers are concerned about the cost of these drugs. Can you just give us a brief summary of how we should look at costs?
Yeah, so unlike many other conditions that might require expensive medications, such as cancer or other rheumatological diseases that may come and go, diabetes is forever. So you have a diabetes diagnosis, and at that moment in history, for the rest of your life, even if you may remit or have a remission of your diabetes for a little while, that is really kind of part of your life. So when we're thinking about medicines that are expensive, we have to be as creative as possible in making it possible for our patients to get their medicines. There is no question that these medications are expensive, and these expensive medicines can prevent a heart attack. So if you don't go to the hospital and have your heart attack, you have definitely saved the medical care system and your own self some time and money. All right. So as we're thinking about this, and we will have other shows within this series talking to you about how to help your patient gain access to these medicines in a way that doesn't make them have to choose medication versus food or housing. We will talk to you about how to help these patients start on these medicines, which have a little bit of side effects, and it is an injectable medication. They have some side effects. They're relatively short-lived, but they can be a bit difficult to tolerate. These are medicines that almost inevitably, by preventing heart attack, stroke, and peripheral vascular disease, will give patients increased longevity as well as increased functional status from not having lived with a heart attack and stroke. So these drugs need to be studied very carefully in terms of cost effectiveness. The other thing is that when metformin first came out, we would not use it because it was too expensive. And now it's $4 a month. So I think we need to understand that these medicines may be very expensive at this moment in history, and that may be a barrier that we as providers have to work within health systems to overcome so our patients can get these transformative medicines, and that also in the long run, they will be incorporated into a pharmacopoeia that people can afford.
Thank you. That's important. Thank you for giving us a wonderful overview of GLP-1, Dr. Ruch. Thank you all for participating in this Heartbeats from Lifelong Learning with us today, where we heard a lot of the important points about demystifying GLP-1. And in closing, I'd like to remind everyone listening to encourage your patients to play an active role in their medical care by advocating for themselves and their family members. Specifically, patients should ask questions about leg symptoms that may interfere and walking and taking some of the other lifestyle choices like lowering their carbohydrate intake and good nutrition, like we've seen on Life's Essential 8. To get additional information and to claim credit, please visit learning.heart.org. The views and opinions in this podcast are those of the speakers and reflect the synthesis of science. The content should not be considered as the official policy of the American Heart Association. Thank you.